like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Sayed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Exciting things are happening at Faisel and Friends this year. Starting next month, we will no longer be going live on social media, but don't worry, you'll find us wherever you listen to podcasts. Episodes will be available every Thursday. Tonight's topic is the role of pulmonology in primary care. My co-host and moderator of the chat is Dr. Dan McCarter. Welcome, Dr. Dan. How are you doing tonight?
Good. It's great to be with you again, Faisel.
It's great to be back. Thank you, Dr. Dan, for covering while I was out ill. I thought for sure it was COVID, but we tested twice and came up negative.
Well, and you covered for me last week, and I was out with COVID. So,
but you really,
I really had it. Yes.
I think it's fitting. I think it's fitting for us to have tonight's topic. I'm really excited about tonight's topic, and also a series we'll be doing with the role of specialists in primary care, especially in the full risk model. So, without further ado, let us welcome our National Director of Pulmonology, Dr. Nina Maouelainin. Welcome.
Thank you. Thank you so much for having me. I'm really excited to be here with you tonight. And I'm glad you both are feeling well. No cough, no sneeze.
I know. I mean, these last couple of weeks. I mean, we've been talking about getting back out again. And over the summer, we were planning on doing a 27-city primary care crusade, restoring the sacred doctor-patient relationship. And then this Delta happened.
Oh, my God.
Squashed that plan. And we started planning again to get back out again out in person, and after Thanksgiving we had this variant, and so it's been kind of slowing us down. Hopefully, this year is going to be the year that we can start getting back out again.
Looking forward to it. We can't wait to travel again and share the love.
You know, Nina, we're so happy. First of all, I'm so happy to finally connect with you, and it kind of reminded me of what it used to be like in residency in the doctor's lounge. When we had our pre-show, just before we went live, that's the way it used to be like. Doctors just getting together, discussing cases, just being chummy, the formality of writing a formal consult, especially for the gray areas. You didn't see that before the way that you're seeing it these days. But before we get into all that, I wanted to hear about your story. You know, everyone has a wonderful story, especially of how we come to deciding our field and how we get to where we are in our lives as physicians. So I'd love to hear a little bit of your background.
Sure. Well, it's a long story, and I am going to cut it short and summarize really where I came from. Actually, I would have never thought in a million years that I was going to end up in the United States speaking English and practicing interventional pulmonology. You would have asked me when I was 10 years old. I'm like, I wanted to be a pilot. Well, here we go. So, long story short, ultimately, grew up in Morocco. I was born and raised in Morocco, and both my parents are physicians, as well as my uncle. And one is a gynecologist and ophthalmologist. But ultimately, even though they were specialists, really, it was funny, I never thought about it that way. They actually were trained by having a very strong internal medicine background. And ultimately, because I went to a French system, I had to actually transition from a Moroccan medical school to a French medical school that was free. I couldn't go to a Moroccan medical school because I didn't have a Moroccan high school grad diploma. And so I trained in France, in Rouen, Normandy. And then after that, politics, social medicine actually was initiated at that time, and they limited the amount of foreign nationals to 10% of a class, which pushed me to continue in Spain. And ultimately, I was worried when I ended up in Madrid that I was going to find myself in the same situation as I was in France if they changed the government again. I'm like, okay, so I'll start. I was supposed to start my clinicals in France. And I'm like, in 2 years, it's going to be time for my internship. What's going to happen? And that's when I started looking into coming to the United States. Ended up in the US. And that's how I embarked into learning English in 1998, went to Juniata College, and that was the pipeline for PCOM, Philadelphia College of Osteopathic Medicine, then internal medicine at Croce Chester, ultimately Pulm Critical Care at Hahnemann, which is no more, which...
I know, unbelievable.
Oh my gosh, that's a whole other... That's what's wrong with medicine today, right?
Yes.
Phenomenal professors, amazing teaching. And teachers. I mean, my pulmonary mentors cried whenever they found out that that was it. I mean, there was always in the background the risk that it was going to be it. But what a loss for the city. What a loss for those that can't afford care.
Yes.
And ultimately, that's where I met my first mentor, Dr. Hogue, who actually guided me in the world of cystic fibrosis. And that's where I was first introduced to really a team approach, a multidisciplinary approach that does what we can do best for the patient, not for the system. Ultimately met with the interventional pulmonologist that made me where I am right now, Dr. Lund. And I ended up at CTCA where I did my interventional pulmonology fellowship, one of the firsts. And unfortunately, because of medicine again, CTCA closed in Philadelphia. And phenomenal physicians had to find their ways again into a very complex, convoluted system and healthcare system. But that's my journey in my learning part. But how did I come about becoming an interventional pulmonologist? That was personal and also a passion and a calling. Personal because I've lost so many family members to lung cancer. My cousin, 25, small cell carcinoma with no access, and also the stigma of not wanting to speak about lung cancer because he was a smoker. My uncle, who also had a small cell carcinoma and was ashamed of it, 56, and ultimately my aunt at age 72 because there was no access. And really, you would think that that was the story of a third world country and only a third world country. Well, to my surprise and sadness, I realized that west of Pittsburgh and east of California is the wild, wild west. And if you actually have a lung lesion, good luck. And so I made it a mission to be able to increase awareness for lung carcinoma, early detection, because it's curable if it's detected early, but more importantly, be able to guide those that really were not aware of what we have from a clinical background, doctors and physicians, as well as patients. And that's how my patient became to be pulmonary and more specifically lung carcinoma and interventional pulmonology.
Wow. Your story is absolutely unbelievable. I cannot even imagine moving from multiple countries. I mean, moving from one state to another state is such a big deal. But to move from Morocco to France to Spain and then moving to the United States and then having to learn all the languages and all the cultures and all the systems and being told that you can't pursue this particular field because there's a cutoff of how many foreign graduates or how many I mean that is just something that is just so foreign, so unbelievable, an incredibly inspiring story with your academic journey. And then what you said about the similarities with American healthcare access, with what many Americans have to deal with limited access to medical care, especially if they have no insurance or if they have high deductibles and they can't afford their copays and deductibles. Really, when you look at the different systems, and like American healthcare system is like multiple systems. But for the people who don't have insurance, what's the difference between what many in the third world struggle with little to no system there, compared to what we have here? I mean, at least here, people have access. If they have an emergency, they can go to the emergency room and they have to be seen. But really, from what you're talking about with being able to address something like an early small cell carcinoma they don't have access. Like you said, good luck.
Exactly. I mean, it's the bottlenecking that's happening right now in medicine. And that's why it is absolutely crucial and important to help and guide primary care physicians, because they're the captains of the boat. And when I initiated programs for lung carcinoma and lung nodule clinics that everybody wants to have now in their healthcare system, because they see it as the ability to get all these lung nodule consults. The goal of having a lung nodule clinic is to be able to detect those that needs care, not the ones that are going to bring you the money. But that's where the disconnect is. And that's why, I mean, when you sit down across the table, and that's why I went and got my MBA, to be able to actually be allowed at that table. You don't have a seat, I pull a seat. And it's amazing, not just because I'm a female, which is a hurdle by itself, but the goal is to be able to really assess from a specialty standpoint who needs to be seen versus the forests of millions of lung nodules that are 2 and 4 millimeters that don't warrant necessarily to be seen in a healthcare system.
Oh, no, they don't want you at the table. The doctor starts speaking like that, the profits start to go down. The complications go down. I mean, all the opportunities to generate revenue go down when the doctor's saying, wait a second, we don't need all that complication.
Correct. And so whenever, I mean, the access to care, like you stated, with regards to carcinoma, we should be at the forefront of delivering the best possible care. We have the means, we have the technology, we have the asset. Why not? And when you dig further and further, the fee-for-service is a big problem. And how many times have I had to go to an administrator or really capital budgeting to be able to justify why we need the state-of-the-art technology to offer the best possible outcome for these patients? And most of the time they're like, clinical, okay, but how about the bottom line? How much is it going to cost? So translate that to literally my 85-year-old COPDer who's living off Medicare, who just wants Symbicort, but cannot afford it because she's on Eliquis and cannot afford it because she's on insulin. To the point, here's one story. One of my 86-year-old patients, when I saw them 3 years ago, ended up begging to go on a cruise way before COVID every single time. And I'm like, you really need to start thinking about this. You're on oxygen, you're going all over the places. And I figure out why. Every single time she stops at a port in a different country, she can go to the pharmacy and get her inhalers for $16 instead of $40. I mean, it's asinine. And I'm like, I'm sorry, what? She's like, I just need the scripts. I'm like, what are you doing? And she's like, it's cheaper down in Latin America, down in the Caribbean, than it is down the street. If that's not telling. So we have a struggle and we are in trouble. And to have a patient not worrying only about their bills at the end of the month, but having to figure out which medication to choose to be able to survive, that is a big problem.
So we have a question.
Yes.
And with the advent of coronavirus and Florona, I can certainly appreciate the ease of access that we provide. For example, cardiology and specialist in-house. Chest physicians should be part of in-house primary care. Are we about to employ pulmonologists across the board? How will operations ensure scheduling timely appointments?
So the key in there is to be able to assist primary care in-house. We do not want to replicate the models that we have right now as fee-for-service, but rather be able to minimize the amount of time the patient is having with multiple figures. You're the captain of the boat as a primary care. If I wear my internal medicine hat, I would love to have access to the actual specialist to discuss the cases. But I do trust that I would be, as an internist for that patient, the best person able to communicate what it is that needs to be done for that patient adequately, in a timely manner, efficiently in that visit. I own my patients. when I was in internal medicine, but definitely as a pulmonologist. And it's like almost a mini primary care in the world of oncology. So when a patient comes to me with a mass, I am holding on to that patient, talking to the medical oncologist, radiation oncologist, radiologist, palliative care, but also primary care, because ultimately, once I'm done, I'm delivering it back to the primary care. And actually, just as a parenthesis in here, I'm always in shock of never seeing a primary care physician at tumor board. Tumor board, where we discuss the path of treatment, evaluation, and ultimately the livelihood of that patient. The primary care is not present. That is a problem. And that's what we're going to work on really improving. So to answer your questions, I do not know for a fact that we will need pulmonologists, at least at this point of time, in-house. Cardiology, much more complex in a sense of subspecialties, from interventional to EP to heart failure, going all the way into transplant. Pulmonology, I'm not saying it's not as complex. Remember, the hot potato, when you're around it, is it the heart or is it the lung? And generally, the cardiologist has the beautiful floors with all the labs and everything else. But no, right now, from the pulmonology standpoint, I think we have a lot of work to do just from the basic standpoint. I'll give you the example of cough. Cough is the dreaded complaint. Forget shortness of breath. Shortness of breath is complex by itself, but cough. How many patients come in primary care office and say, I have this cough and it's not coming away? And you throw everything at them, the kitchen sink. But really, a pearl in here, when you have cough, it's very complex, especially chronic cough. But I think the key is to just be able to learn how to interview the patient the right way, in a sense that cough can be only in the morning or only at night or throughout the day. Is it dry? Is it productive? And each one has a different pathway. And what we worked on with the leadership of Scott is to be able to develop these clinical pathways to guide the primary care physicians, so there is less time waste and we are much more efficient in being able, as we are with the patient, to ask the question to appropriately guide your care. Ultimately, once all that's done, that an internal medicine or family doc should be able to do. And unfortunately, I mean, that's a whole other topic from the education standpoint and from how much time really we're spending in the outpatient with COVID. And fortunately, all the new grads are drowning with inpatient training and hardly no outpatient training. And that is a challenge. So I'm hoping by initiating the subspecialty teams, we are able to really guide you through clinical pathways to ultimately get rid of that bottleneck that's happening right now in most of the specialties, specifically pulmonology offices. All the offices that you see and that I've spoken to lately, it's COVID, 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 lung nodule, COVID, 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 COVID. And the main complaint is cough. So I'm hoping that the clinical pathway would be the first step, and then we'll go from there.
You know, you talked about how you'd be sitting in these meetings with administrators who are looking, you know, you have noble doctors, noble nurses who have this calling to do good, to help people. You know, we have these incredible driving forces that make us want to do good, want to make a positive difference in our patients' lives. And then you're in a system that actually benefits more from inefficiencies and mismanagement. You know, so then you have the doctors are constantly struggling. The doctors and nurses are constantly struggling to deliver better care. So the system in itself, you know, if you look at, we have 1 million doctors in America. About 800,000 of them are specialists. Only 200,000 are primary care doctors. And if you look at the number of primary care doctors, there's only like 100, maybe 110,000 family doctors. Small number of primary care. And 1 to 2 out of 5 are nearing retirement age. So we have a system where primary care is, you know, we're trained, we have this extensive training in family medicine, internal medicine, and then you come out into the world and you're limited with your scope of practice. Suddenly, when you take that entire system out and you have a system that is driven by primary care, and the primary care doctor has the time and the teams and the resources available, then something like a cough, you have the time to be able to look into, okay, what are you dealing with? What is this cough that's in front of you? What is going on in the patient's life? You're not just quickly running through the treadmill, as Dr. Dan likes to talk about, 25, 30, 40. We met a doctor who's seeing 50 plus patients every day. How in the world can that doctor take the time to properly evaluate a cough? Of course, he's going to refer that cough to the pulmonologist.
Yeah. And actually, that patient, you know what they ended up doing? They went to see the ENT, they did an NPL, they went to the GI, they did the EGT. I mean, actually, when I was interviewing Shemin, that was the story, my Mark story. I'm like, guys, please, can we stop this madness? By the time she came to me, it was to get a bronchoscopy. And I'm looking at her and I'm like, oh my gosh, this has been going on for 6 months. You've had every possible inhaler, every possible nasal spray, an NPL, an EGD, risk of anesthesia, forget about all that. Ultimately, I sat down with her, and when I opened up the private practice, originally, shine away from every possible system, because I did academia, for profit, nonprofit.
Wow.
And ultimately I said, no, I have to do it my way. Direct service care is the way to go. And you pick your time. So you know what she had and why she was coughing for 6 months? Resin. Violin.
Was what?
Resin. She changed her resin for her violin. That was her hobby.
Oh.
So and when the resin was changed, she actually developed an allergy that caused her to cough every single time she played.
Wow.
So I told her at the end of the visit, I'm like, bingo. Like, you know what? No bronchoscopy. She looked at me. She's like, why? I'm like, no inhalers either. She's like, nothing. I'm like, stop the PPI. She's like, well, hold on, doc. What are you saying? I'm like, do me a favor. 2 weeks. No medication.
That's so incredible.
Guess what? I'm like, you'll call me. And by the way, enough with the post-op follow-up just to follow up. That is a nightmare. If the problem is resolved,
exactly,
go live your life. And so anyway, so 2 weeks later, she left me a message, doc, no cough.
Yeah. Well, but I mean, what you're describing is what one of my mentors used to say is if you listen to the patient long enough, they'll tell you what's wrong with them, but they won't talk in medical terms. You've got to really be open to what they're talking about. And but it's difficult. Patients very often want to come in and they want a pill and they want a cure. They don't want me to tell them to go, I want you to keep a symptom log and let's look at when you're having symptoms and see what we can figure out by looking at that. Because if somebody will really do that, they'll often come back with the answer themselves, right? You don't have to go through the log. They've written it down and they've now seen it. You know, I think it might be coming from this, that, or the other thing.
You're absolutely right. And when I did my programs for the in the area, because I just couldn't see any more patients, I started having videos for the patient to teach them how to really live better, be healthier, promote lung health, little changes in life as you go around. And I think primary care are in the best place to do that, little things at a time. But like you said, I mean, same thing as my mentors. They said, hey, the patients have the answer. If you listen long enough, you'll be able to figure it out. And yes, absolutely agree. So hopefully by providing the right support, the right guidance, and more importantly, how to learn how to listen, right? Listen to be able to find the answer in the mumbo jumbo that the patient is bringing to you. Just try to figure it out instead of fitting them into your diagnosis or fitting the diagnosis into them. Try to use their tools to be able to fit together for them specifically. And that's the beauty of being able to spend the time that you can as a primary care with the patients.
So we had another question earlier. Looks like Dr. Joseph was asking, what are your thoughts on the primary care first model? And that is really taking the place of the CPC plus, and it's a CMS model, direct contracting model with primary care doctors to do a prospective payment first to encourage them to have the case management resources they need. And I don't know if you've had a chance to look at that or what your thoughts are about that.
So no, I haven't had a chance to look at it, but just from your short explanation, I think that ultimately any model needs to look at the outcomes and more importantly, the impact when it comes to disease progression, admissions, And I totally agree that you absolutely need to have the support from the social standpoint, case management, DME companies, nutrition, physical therapy, any of the ancillary support that can be provided to the patients. And if anybody is willing to give us that bundle with all of it, by all means. I mean, lung cancer, whenever I diagnosed patients with primary tumors, and they're like, we want to go to the best hospital possible and imaginable, and the standard of care can be given in the infusion center right next door. The conversation that I have with these patients is ultimately, where is the case managers? Where are the social workers? Who's going to take care of the transport? Who's going to allow you to have the best possible nutrition? Who's going to be having to take PTO to take you wherever you need to go? And do you have the support system right there and then? So any model that will be allowing primary care physicians to have these multidisciplinary team available to them without having to go hunt them down. I mean, our referral coordinators are having to literally learn the system, even though they're not necessarily clinical. And that's why the specialists are coming on board to help them with the CPLs, to be able to really define who we need as a partner, as a team member, to provide that resource. I think that would be a win.
And in addition to that, to the support, we need the data. So right now we're able to have access to near real-time data with where our patients are, exactly where their needs are, if they're in the hospital setting, if they're in specialty setting. We're able to have near real. We cannot wait months to have retroactive data. We need data real time.
And you have to impact it real time. Yes. I mean, my team, when I started the actual pulmonary interventional pulmonology program, grids, data. And they looked at me like, grids? I'm like, yes, I need grids from day one. That's what so I'm the grid IP, the grid lady.
Well, I would like to take a quick pause. We need to take a quick 20-second commercial break, and then we're going to come back and talk about Nina's role with ChenMed and her vision for pulmonary disease management in our full risk primary care delivery system.
ChenMed honors seniors with affordable, top-of-the-line care, and we're expanding. We're opening 25 new centers this year, including centers in 2 new cities, Houston and Detroit. Join us as we bring better healthcare to more seniors. Head to chenmed.com/physicians for more information.
I just realized something. We need a new commercial, Dr. Dan. And it's not just 2 cities this year. I mean, my goodness, we're moving into more states than we've opened in cities, in the past. So it's really quite an exciting year. We're growing much more than we did last year, probably double what we did last year, realistically. But again, for the closing, Nina, we would like to hear about, how you found ChenMed, how you've come here, and now what is your vision for pulmonary disease management in the primary care setting, using all the resources and the flexibility that we have with the full risk model?
So how did I find ChenMed? That is really a funny story in the sense that when I built my interventional pulmonology practice, my goal was to be able to really define a model that was non-existent in specialty care, which is to try to limit the amount of bottlenecking and access or allow patient access to subspecialists to get the best possible care. And the problem was, whenever I worked with hospitals, is that I was really limited the patients were limited in seeing me. If they were not part of a certain insurance, they weren't able to see me because the hospital was not part of that insurance. That's why I said goodbye to the actual hospitals and I opened up a wide open free access, whether you have insurance or not, whether you could pay right away or not. If you have a risk of lung cancer, here we go. Ultimately, 3-4 years later, with data and grids, it was time to scale. But then I realized that the majority of the time was spent in educating primary care physicians, in helping me limit the amount of referrals that were actually occurring, so allow the patients to see me. So instead of sending me somebody with a cough, remember when we used to do fellowship and residency? I would, at least when I was an intern, God forbid I would pick up that phone and I would call the cardiology fellow with the consult of shortness of breath. I think I I would have been like on the pavement at that point. You should have seen that. I had to have my list with the EKG, with the echo, with this, and here's my thought process, my differential. I used all my resources. Now you're the god of cardiology. Please tell me what's going on. And that's how we were able to function and learn. So when I looked back at the data and I saw that the majority of the referrals were coming through, actually, the majority of them were not coming from oncology. The majority were coming from primary care physicians. And then when we looked at the type of referrals that were coming through and how many of them were really not investigated correctly, or worse, if they actually had a mass, they were sent directly to oncology. They don't have tissue. Oncology wasn't going to do anything. So they were sent back to the primary and then back to IR.
Yeah.
Or RP. That's when, as I sat down, and actually it was on LinkedIn, and I heard, that's how I heard about ChenMed. And that's how the recruiter got a hold of me. And ultimately, when he talked to me originally, and I'm like, what? You do what? What's the model? It was like, ta-da! Here you go. We want to scale the mindset. Like I said, it's a calling, it's a passion. It's not about business. It's about being able to help as much as possible. So yes, from the business standpoint, people are like, what are you doing? You have a thriving business. You can scale it all the way up. What are you going to go do? And I'm like, exactly what I'm meant to be doing, which is to literally replicate, in a sense, this model where we can guide and teach primary care how to really send the very sick upward toward the specialist, but also the impact occurs on the specialty side. The specialist needs to stop thinking fee for service, but rather effectiveness in curing and helping patients. And I think from within, we can actually combat the beast of healthcare that we have right now in the United States. So by coming to ChenMed, my goal, hopefully, in helping actually scale a model of value care, and more importantly, guiding the primary care physician in gaining back what has been lost for such a long time. The majority of the system has been using them as a triage system. I mean, look what happened with the ER. We didn't even used to have ERs my parents, they used to take turns in the ER. I couldn't imagine right now having an internal medicine doc taking turns in the ER. It's just not happening. I mean, training, when I did my training at PCOM, we had to go in Sullivan County, LaPorte, rural Pennsylvania, for a month. We knew how to shoot our x-rays, how to do our EKGs, we were at 100-mile radius. It was like Big Brother's house. The clinic was underneath and we were above, 7 students, medical students. So that has been lost, I feel. So by coming onto the ChenMed, from the pulmonology standpoint, my hope and goal and aspirations is to be able to give that powerful tool and clinical pathway to be able to guide the primary care physicians to stop the bottleneck. And like I said, help them be confident in being able to manage what we consider in pulmonology a simple disease, although it is complex: emphysema, COPD, asthma.
Sure.
It's simple at the beginning, but as it progresses with all the other variables that actually come with it, it becomes more and more complex. So by the time it becomes complex, hopefully the primary care physician would have actually guided the patient, prepped them, so when they escalate care, it will be the absolute specific specialty care. And then the specialists, as we meet with them, and we are going around and defining who they are, we will sit down across the table and tell them, here's the deal. These are our patients. They're dear to us when we want them to get the best possible care with the least amount of waste of their time, of their money, of their health. Bringing them for a visit for the PFT, sending them back, bringing them to order account, sending them back, bringing them to get a PET scan, sending them back, and the oxygen and the tanks and the risks of falling, all of that, no good. It needs to be a one-stop shop.
Yeah.
So with the help of the primary care, we will be able to define the issues and the diagnoses, do the basic workup, and ultimately, when they go packaged to the subspecialist, they truly get the specialty care, not the primary care at the specialty care. And that's my hope.
Wow. I feel your passion. I'm so grateful. We're blessed as an organization to have you with us. And, you're right. If it's not efficient, it's not effective. And if it's not effective, we're not improving health. So thank you for joining us tonight, Dr. Nina Maouelainin. It's
My
been such a
pleasure. Thank you so much
pleasure
for
to
having
have you
me.
join us tonight. Gosh, Dr. Dan, what a wonderful conversation.
Absolutely. I mean, it's so exciting to have specialists who are as passionate about providing the outcomes for our patients as our primary care doctors, and how we can all work together to raise our level of care is just huge.
Wow. And to our audience, thank you so much for joining us tonight as well. For more information about tonight's topic and to explore career opportunities with ChenMed, please visit chenmed.com. We believe access to primary care is a right, not a privilege.